All right, good morning. It's April 16th. This is Center for Health and Welfare. It's a beautiful day outside. And we are considering H 721, trying to get to some final decisions around expanding access to Medicaid and Dr. Dinosaur. We heard from Diva the other day on the bill. And we have taken testimony. This morning, we're going to hear from Jessica Barnard and Mike Fisher, both VMS, Medical Society, and Office of Health Advocate. So if you want to go first.
Good morning. Good morning. Thank you for having me, Jessica Barnard, the Executive Director of the Vermont Medical Society. I'm going to focus largely on a piece of the bill you haven't actually talked about quite as much as the MSP piece, which is the expansion of the other programs. But let me first say, we do support as an organization universal access to comprehensive, affordable, high-quality healthcare. We do support the MSP expansion in Section 7 of the bill. We also support exploring expansion of the Medicaid program for more Vermonters. We strongly supported the technical analysis in Section 4 of the bill. We think answering some of those questions that analysis would dig into is really important, especially before broader expansion. So and you heard some of these questions actually from Diva. Our biggest question is sort of who would be coming on to these programs and what insurance do they currently have? So what would be the impacts both in terms of federal funding, cost sharing for the individuals, and also reimbursement rates for clinicians and healthcare facilities. So that, again, that technical analysis is really important. And I do want to go into a little bit more, I'll try to keep it high level, but some of the impacts on providers when folks switch from potentially commercial insurance, if that's what they had. So some individuals could be uninsured. But some could be coming from employer plans or the qualified health plans. So we do know that overall Medicaid for most services, and I'm going to be talking about the Medicaid fee for service, what they call their RVRVS fee schedule. That is not what every provider gets. The FQHCs have a different fee schedule. But for the majority of professional services, Medicaid reimburses at about 85% of Medicare. And then Medicare, and then commercial, so it's Medicaid, Medicare's sort of in the middle, and then commercial on average, based on sort of national analysis, is about 143% of Medicare rates. And then I will say, so I'll be talking about this a little more, there is a separate enhanced primary care fee schedule within that. So on average, Medicaid pays 85% of Medicare, but for a subset of primary care clinicians providing some types of primary care services as defined by Diva, they are currently getting 110% of Medicare. So actually above the Medicare fee schedule, which you folks did a year ago, which has been very much appreciated and made a big difference for the sustainability of primary care in our state. So most of the conversation in the House about 721 was sort of around what questions we would want answered for a broader expansion of Medicaid. And it's going to look at some of the different reimbursement rate structures that could apply to the expanded population. And other states that have public option programs, they've done similar sort of analyses, and they've actually set reimbursement rates closer to commercial rates to ensure access for patients and participation by providers. So I've included some references to for example, Washington State and Colorado and Oregon, kind of what they've actually ended up at a percent of Medicare ranging between 135 and 160% of Medicare rates for their expanded kind of public option programs. And so the assessment or the technical analysis asks for Diva to look at, well, what should we benchmark this reimbursement rate at? Should it be a percent of Medicare? Or actually, should it be a percent of commercial? Because there have been some issues over the years with Medicare's fee schedule actually being reduced year after year. It's received cuts the past couple of years, so if we're benchmarking to a decreasing rate, is that really how we want to sort of sustainably fund a program? So those analyses are built into the study. When the bill sort of at the end of the House deliberations, they added back in the immediate, the sooner expansion before this technical analysis was all back, the 18 to 19 and the pregnant women up to 312% population. We understand the sort of urgency, the desire to move forward. What we would ask for, if that is moving forward, is that rather than waiting for all the technical analysis to come back about reimbursement rates, is that some of the really core services that we actually think already should be defined as primary care be reimbursed at that primary care rate that I said is 110% of Medicare, rather than the standard Medicaid rate, which is 85% of Medicare, lower than Medicare. So those are some of prenatal, labor, delivery, and postpartum services, reproductive healthcare services, and some of the most common psychiatric or therapy services. So in our view, those actually already should be defined as primary care, but they are not. So those are at the below Medicare reimbursement rate. And I'll give you some of the reasons why we've kind of honed in on those services. So because of the expansion to for the pregnant population, Vermont already has the lowest birth rates and lowest number of births in the nation. Our labor and delivery units are already really struggling. You're probably well aware, for example, Springfield closed their labor and delivery services in 2019. In New Hampshire, 9 out of 16 rural hospitals have closed their labor and delivery units because of declining birth rates and financial pressures. It's a nationwide issue that labor and delivery services are not reimbursed well, and in states with declining birth rates, it's really impacting them. I think you've heard from Diva. We think that this expansion would increase the number of births covered by Medicaid by approximately 657 per year, which is not an insignificant percent of our 5,100 births per year. So I included in our written testimony the codes that would cover the most common sort of prenatal, delivery, and immediate postpartum care services that we would request to be included in that enhanced fee schedule. And then reproductive healthcare providers are also struggling. Planned Parenthood testified upstairs that 5 health centers recently closed. They're facing a $3.9 million deficit in their 2024 budget. So especially with this younger and also postpartum populations, we think reproductive healthcare services will be particularly important. And again, these are really things we already think of really as basic primary care services. There's also been a recent, and actually I will fully acknowledge I have not had time to discuss this directly with Diva, but there's been, potentially either a misunderstanding or a lack of clarity around whether OBGYN providers at all can attest to being primary care providers to participate in that enhanced fee schedule. So I said it's kind of a 2-part test. You have to attest to being a primary care provider, and then they list codes that are considered primary care codes. Our understanding from Diva and my past communications with them said that OBGYNs or reproductive healthcare providers can attest to being primary care providers. But we've recently heard of OBGYNs trying to submit that attestation form and being declined by Gainwell. So that could be a Gainwell-Diva miscommunication. I'm not quite sure, but we would ask for just explicit clarity.
Gainwell?
Yeah, sure. Gainwell is a contractor of Diva's, and they could clarify better from my interactions with them. They help with a lot of the provider enrollment. For provider credentialing, provider enrollment, processing some of the paperwork. So that's where you actually submit the form that you attested to being a primary care provider to.
So you want us to ask Gainwell if we should do this?
Well,
I think we're probably not going to ask that question, but.
No, our request would simply be to just clarify explicitly that OBGYNs can be in the category of provider that qualifies to be primary care. Because there's been enough back and forth over the years of yes, no, are they not? The form is rather vague. It basically is a self-attestation form. And the feedback I received from Diva is if they think the majority of what they do is primary care and feel like they can self-attest to being primary care, they can. But it would be, we think enough OBGYN services are basic primary care that it should just be clear we could need that test. So I've listed again, the most common contraceptive care codes, psychotherapy codes, and prenatal and delivery care codes that we would ask to be in that enhanced rate. If these expansions move forward this session, we really think it should be paired with, we're expanding the folks who are eligible. And they will be receiving, especially the prenatal care that is really the point of them receiving this coverage, that this be available at the enhanced primary care rate. Rather than wait for the assessment to come back at a later date.
Can I ask a question? This might be a silly question, I don't know, but the enhanced rate is based on Medicare rates. A certain percentage of Medicare rates,
Correct.
are these codes even used by
Yes.
Medicare? Because they're
They should be,
they're probably not
yeah.
services that are covered by Medicare generally, given the
Well,
population that is Medicare.
It would be less common, but they should still be covered, they should still be addressed by the Medicare fee
You have
schedule.
dual eligibles tonight.
Well, I understand the question, right, you're saying that these might, but think that, like, there are folks with, on Medicare for disability eligibility could be all ages. So they actually do have fee schedules even for pediatric care, vaccines, I mean, that's a lot of the, current codes in this enhanced rate are actually pediatric type codes, and they do have, that the Medicare fee schedule addresses really the whole gamut of services. Even though
Okay.
they may be less commonly used for Medicare folks, it's still addressed in their fee schedule.
Okay.
But, yeah, good question.
Other questions?
All right,
Okay, so we'll talk with Ledge Council about possible language.
Thank you very much. Thanks for taking the time.
Welcome.
Madam Chair, if I could bring up Emma Davis with me.
Sure.
We introduced,
That's not right. Do a little rearranging here.
let me just, Mike Fisher, healthcare advocate.
I'm Donna, I'm a consumer research and health policy advocate.
So let me just take just a second to say, Emma has been the workhorse behind the MSP project. Every single piece of paper you've seen me, every analysis, this is Emma's work. So let me bring her up.
And do we have this on our webpage?
So I did just send it.
She just shared it.
Is it the legislative priority expand from you? Is that one? Is it PowerPoint?
Yes.
Yeah.
I also have paper copies if anybody wants that.
I'll take one.
Oh, okay. I'll take one.
Thanks, sure.
Keep it one.
Keep going.
Madam Chair, if you could direct us a little bit about timing. If we could do this,
Well, I think
we
the
could do
quicker the better,
it very,
because we'd like to bring our Ledge Council up and go through the bill from Martha.
so we're gonna skim.
Okay.
That's what I thought your answer was gonna be. So there's a bunch of slides in here. We're really just gonna say, just reference for us.
Our goal today is to make some recommendations to appropriations as we pass the bill out, so
And
we
that's what we'll,
absolutely need to do that
we'll
today.
focus on. Here's the HCA team. I'm gonna recognize that all of this starts with people's voices. Here is a slide where you can click into and get actual Vermonters' voices about the challenges they face. And audio clips from them. We did a decent amount of work engaging with people, and bringing people's voices to the table is always important, even if it's just to reference them. We want to remind you that there's a very broad coalition of people who support this. It's kind of a rare day where you have the likes of the Hospital Association and Blue Cross and the HCA and many, many others. This is a broadly supported proposal. Just quick break. So you know the picture of the Medicare cliff, that is the motivator, if those want to put that image in front of you. I want to just take a second to say something that I don't think has been said very much is in this room, though I think everyone here knows it. Who is it who is very poor on Medicare, retired and very poor in Vermont? Of course, all shapes and sizes and colors and genders are very poor, but there is a disproportionate number of people. It sort of boils down to who's been paid less through their careers, who's been underpaid through their careers. And it has a sort of cumulative effect. And so not surprisingly, women get 59% of what men get in social security benefits. Women are disproportionately poor in retirement, and people of color as well, and people living with a disability. And therefore, this bill, it seeks to solve some of that, so it has a disproportionate positive impact for those populations.
It's a nice way of saying it. That's a good way of saying it.
Yeah.
I appreciate that. Thank you.
Yeah, and let's just get this one. Do you want to?
Sure. This is just a quick reminder about the Medicare Savings Program. I know that Diva covered this the other day, but there are different levels. There's the qualified Medicare beneficiary level. That one helps with cost sharing. So it pays the Medicare Part A and B deductible and co-pays, bring those down to $0 when you go to the doctor. It also helps pay your Part B, your outpatient premium, which is the monthly cost for folks. It comes out of their Social Security income every month, the money they need to live on.
I know we're in a hurry. Can we slow down a little bit on this page, just a little tiny bit?
Yeah.
Okay,
Sure.
Thank you. I
That's
didn't
up
mean
to
to
the
interrupt, but
presenter,
I just.
but we'll just,
There's
we're
a-
gonna
wanna make
push
sure.
it slow,
Yeah, so,
just to offer clarity.
yeah, no,
It's so
definitely.
simple. It's all so simple.
Yeah, so the qualified Medicare beneficiary is the level that helps the lowest income people to qualify. And it helps with their cost sharing. So the Medicare Part A, that's their hospital insurance. B, that's their medical outpatient insurance, brings those costs down to zero. Otherwise, there's large deductibles, 20% cost sharing. It can be a lot of money to get the care you need, especially if you're low income. It also pays your Medicare Part B monthly premium. That's $174 every month in 2024 per person. If you're in a married household, you're both on Medicare, that's double every month. Comes out of your Social Security check. This
And
lets
this
it,
is an important point, because I think
Yeah.
people don't realize that you actually pay a premium
you
for
pay,
Medicare.
exactly.
And
People
when
think it's
social
free, but-
security increases, the premium also goes up.
Yes.
Surprise, surprise.
And
Yes.
that 174 might not sound like a lot of money, but for the people who are just above the eligibility for support, for that support, 10% of their income for a family of one, for a family of two, is 15% of it.
Yeah, it can be a huge amount of money if you're living on very little in retirement. So the qualified Medicare beneficiary program lets you keep that money in your Social Security check instead of sending it away to the federal government. QMB also pays your Medicare Part D, your prescription drug, your premium, the big deductible, your co-pays, it significantly lowers them. That's 100% federally funded. The next level of MSP, Medicare Savings Program, is the qualified individual. This is for people who have income that's a little bit higher. They're still very low income folks, but it's a little higher. This helps with the Part B premium and your D prescription drugs. It doesn't do the cost sharing piece. And I'll just click quickly. So QMB is largely, it's the FMAP. So there's a Vermont funding and federal funding. QI1 is 100% federally funded, which is why so many states, including many of our neighboring states, have expanded this program to take advantage of that huge amount of federal funding that we're kind of leaving on the table right now.
All right. Here's a picture of what other states, our neighboring states have done. DC is maybe a different animal altogether, but they're the state that's done the furthest. And just a recognition, we added the Vermont House position is the same as Massachusetts here. And the bottom red is Vermont's. So other states have seen this, recognize the value. And I understand Rhode Island is in pursuit of doing it this year.
The red is what we're currently doing.
Yes.
These are the only states that have done it? You said neighboring states, because Indiana's
These-
not.
Yes, yeah, Indiana's not, no.
Yes, they
Maine,
just-
New York,
Geography.
Connecticut.
You're right.
Got it, clearly.
These are the states who have done it, many of them happen to be.
Okay.
Okay,
It's an exclusive list?
Yeah.
Okay.
every other state and Vermont has a federal minimum.
Yeah.
So the next slide is way too complicated, but I'm gonna just pause on it for a second, because I think here is sort of the heart. Yesterday or the other day, Senator Hardy made the point of how much federal revenue gets drawn down. We wanted to sort of explore that for a moment. So the top line is the House position, and I'll just sort of walk through that. Well, maybe I won't walk through all of it. You see the total net new MSP enrollees sort of in the middle, 19,217 expected new enrollees. And the general fund cost of 15 million. Now, everything to the right in the green is drawing down federal dollars, return on investment. And the first column, the federal match, is the sort of the balance that you see in Nolan's charts. That's just sort of the direct federal match rate. The last two columns are columns you haven't seen, because that's money that comes sort of more directly to people. And so it's not a benefit to the state, but it's a benefit to Vermonters. So a key one is the column Part B premium savings. And this is the one that Emma mentioned a moment ago. It's the money that comes directly out of people's premiums. If we covered 19,217 new MSP people, Vermonters, that would mean $40 million going directly into people's pockets. Yes. Well, with that
Instead of that.
$15 million investment on the state side, that would be part of the return. And then the last one is the value of the federal low income subsidy, federal restricting drug.
Question.
What was your point about that, money going directly into people's pockets? Is that gonna benefit the medical?
So the Part B premium savings is money in people's pockets. It helps them buy groceries, heat their homes. It just helps them. Again, we're talking about, I want to repeat, 10%, $2,000 a year in Part B premiums is 10% of an individual, the poorest people who are getting this new benefit.
But it's not gonna help them offset medical expenses if they don't spend it.
No, there's other lines that do that. That one just helps them directly. This is not a full picture. There's also a reduction in out-of-pocket costs. It's not captured in this chart. And there's the column all the way on the right, and that's the prescription drug benefit, which does help them get the care. So you can come down the different options that have been put in front of you and see just sort of focusing on for the state investment, whether it's $15 million or whether it's $4.7 million, the number of people who get brought in and the value of that investment for Vermonters. And I guess I just want to pause and recognize, I heard the chair say a second ago, budget's a $20 million whole challenge, difficulty at the moment. I know money is scarce. And I know advocates like us come before you every day and say, spend money on this, it's important, and it is. And I know you know it is. I guess I want to recognize, I guess I'll use this. I recognize that we will not achieve what the House position is in Senate this year. No, that's not going to be a newsflash. It's certainly what we would advocate for, but we're not going to get it. And I don't know what we're going to get. That's yet to be seen. But we have talked over the year, in this, I want to recognize that sometimes we have to do stages. Sometimes we have to do steps. And this is not an easy thing to step. requires DEVA to go get approval from the feds and to adjust their IT system each step. And I know DEVA won't be a fan of this concept, but I just want to at least put the idea out there. If, for instance, we did an option B, that there's still opportunity to draw down more dollars for low-income seniors. And maybe it makes sense to offer some kind of language that says, hey, DEVA, come back to us in 2 years with an analysis of what it would take to do this.
So that can go in the technical analysis.
Could go in the technical analysis.
Whatever, wherever we land, we also could ask for additional information.
Some kind of trigger to ask whoever's sitting in these seats, maybe 2 years later or next year later, to come back to this topic.
Absolutely.
So,
And before we switch slides, I just want to say, so the top 3 rows, it brings the Medicare Savings Program to 225% FPL. That's the V-Farm cutoff. The current V-Farm program helps people with their Medicare prescription drugs. And we'll get into this in the next slide or two, but the funding structure is pretty inefficient, which is why we would, ideally, the state would want to move the Medicare Savings Program to 225 to top. Because then you can move those folks onto a 100% federally funded prescription drug benefit, which is obviously for state dollars. Wow. Lots of excitement.
I think,
Hold on a sec, we have.
Yeah.
Before you move on.
Oh, yeah, absolutely.
In the last slide, so the 10.1 million, when it came over from the House, was 22 million, is that the extractions that reflect the extraction of the 26-year-olds? Is that the?
Medicare savings.
the portion of the bill that funded the Medicare Savings Plan is the top line, 15 million.
Wasn't the total cost originally when it came from the House 22 million?
And that additional about 15 to 22 was the Dr. D expansion and the study. Yes, I believe you're right, with the 22.
Yeah.
The Medicare Savings Program part was 15 in the House. Okay.
So I think we should stop doing details. I mean, I think you said everything to say.
Sure.
Yeah. There's a
I'm
couple
going
of,
on the bee farm.
there's a couple of additional slides just for you to see, and just a reminder about the cliff that we're trying to. If you look at the slide for a second, look at if this is one of my favorite visualizations. If we could eliminate the cliff just with the push of the button.
I think there's a lot of agreement about that.
Yeah.
How do they get there?
So I think the main thing I want to just pause and recognize that I know everyone wants to do more than we're going to achieve this year, and I appreciate all of the support and focus and the new understanding about what the Medicare cliff is, and happy to answer any other questions.
Questions?
Thank you.
All right. I think we're good to go away, because we're gonna bring Jen up and we'll have a discussion. Oh, there it is. We'll have a discussion as we go through the bill. We've heard from DMS and we've also heard from you, and we've got we heard from DEVA, so we have some decision making to do. So Jen, you want to
Yes.
help us go through the bill, and I think let's start with the cost estimates for various programs, and that those are the back sections. I forget which section it begins on. Is it 6? 5? No, 7 is one. You can help us go to that first, and then we'll go to the technical workshop in 4. technical one also.
Okay, good morning, Jennifer Kirby, the Legislative Council. So we are.
Yeah.
So you wanted to start the Medicare Savings Program section?
Let's do that.
So as it came over from the House, and as you just saw on the chart from the Healthcare Advocate's Office, the House version would direct the Agency of Human Services to change the income eligibility for qualified Medicare beneficiary QMB to 190% of the federal poverty level, the SLIMB income threshold to 210%, and the QI income threshold to 225%. And going along with that, there is a repeal of fee
So,
farm when these become effective.
and then B farm, which was not touched, well. Gone. So if we look at the Diva spreadsheet while we're looking at this. Well, let's keep going and then we'll come back and do the Diva spreadsheet process.
I'm not sure what you want, so I mean, there's sections that go along with that around getting a Medicaid state plan amendment and then the repeal of fee farm. Corresponding to the increase of QI at 225.
Right. And once it goes up to 225, then it sort of reaches its limit.
Right.
And I noticed that in your slide, that which state was it? Massachusetts or another state went over the 225. The implications of that are spending by state funding. What are the implications of going over the QI 225?
I think, Mike Fisher, I think 225 is important for Vermont because our prescription drug program caps out at 225. I don't know what.
Oh, I got you.
What
Okay,
Maine's
stated.
was, or Connecticut's was,
Yeah.
and whether they were motivated. But I think the real issue is the higher we can push that number, the more people we provide it for. And the more it costs.
And the more.
I think I already know the answer to this, but I
Just ask it.
I'm
Somebody
gonna
might
make
know.
sure. So the alternative option that y'all are proposing, like, it would end V farm because it would no longer be necessary and we wouldn't have to do slim because we've hit that sort of sweet spot, right? Okay, so it would just be QI 1 and
Yes,
QB.
yes.
Okay.
And can I just say, I think what the language in the bill says, and I think it's good, is that we would give B farm a year. We would give the administration, it would be eliminated a year out and ask DEVA to come back in the interim with proposals about what exactly to do to support the programs. B farm's a good program and we should be proud of B farm, and it does provide important supports and it's costly. So giving ourselves that year to sort of figure out the best way to chart that makes a lot of sense.
So I'm looking at the Diva proposed options that we had on Friday. And then as I went through it over the weekend, thinking about what would be of best benefit to the most, and looking at the V farm's 70% coverage, and looking at option B, I automatically threw out option C. But then consider option B as something that we might want to hold on to. Because it will.
Which leaves
I'm looking at this.
Right, I'm trying to put it up, so.
Are there A, B, and C
No,
that they
it's
would
what I
like?
sent,
A, B, and
it,
C?
it relates to the email that I sent over the weekend. Tried to walk us through that a little bit and make some considerations for
Is the same,
possible budgetary implications, what we might be able to do down the hall. And that's really, I think, very important. So looking at option B, I think we can handle that. Or at least the appropriations could handle that.
So I'm looking at your email, and I'm not sure.
Okay,
option A
what-
versus B.
I'm looking at this one right here, and it's not related to Dr. Dinosaur or the pregnancy piece. It's only related to the Medicare savings programs here. So that we're looking at Medicaid expansion of young people and those who are pregnant. That's a separate question. And then we're looking at Medicare, expansion, to help folks who are older or disabled and what we can do to expand their coverage based on their income. The three different prices. So that. Okay, so that's my 2 cents, and it was my 10 cents over the weekend. And seriously, after talking with folks in appropriations and what might happen, could happen during the appropriations process, not just with us, but with the House as well. So let's move to, unless there are questions, then
So what is the goal right now?
we're making some decisions.
And you're suggesting alternative B?
I am.
Which is 145 and 190, and keeping B farm at
70%,
B farm 3 at 70%.
which is better than the other two options where drugs are extremely costly. And it's,
I mean, have you been given a number from
I've been,
appropriations that we're supposed to work, like a box that we're supposed to
not
work?
really, not
No.
really.
And are these new revenues off the table? Where are we at on the new revenues?
That's a question I can't answer. That's a finance question. We're not doing everything in here. We're trying to make a recommendation that we believe can go forward. And that won't, I mean, if we were to take, honestly, if we were to take the House passed recommendation, it wouldn't go forward. And I think the House even understands that at this point. When they passed this bill, as well as when they passed the GA 879, they were very, all encompassing, trying to do as much as possible. And the reality of our budgetary place has hit. So we are $20 million behind. And
But that $20 million doesn't include new revenue. I mean, the House.
no, it doesn't, but it also, there are other things that we would like to support, for example, we want to support our DAs and our SSAs.
No, I understand that. I'm just saying that this bill came with new revenues, as did several other bills. And so I'm trying to understand if the Senate is willing to consider new revenues in order to.
That would be a
To
question
fund
that
some
will
of these
happen
things.
both in finance, appropriations, corner office, and our recommendations. So we can't debate that. We could say, yes, we want to raise more money, but we could try that.
Because I think that
What are you looking at?
well, I mean, I personally, like the alternative proposed by the healthcare advocate, because it covers a lot more people.
Which
And
is,
I think it's alternative option in both of them. So it covers almost 16,000 people and draws down a significant amount of federal funding. I mean, if you look at that from the perspective of how much federal money we would get, not only the state, but individuals would not have to pay their premiums to the federal government.
it does put us at the top of our QI. That is a concern.
what do you mean?
25. Yeah, expand beyond that.
Well, that's the V farm level. Right, so I think you can, I think that just some others have. Other states have, Maine has.
But they have
and
different,
Connecticut
but they,
has.
they have different caps. This is the point. So different states have different caps based on their financial situation.
Well, I mean, is it a problem going up to, I mean, is there a negative to going up to the?
I was gonna ask that too.
We can ask Eva that question. I think so. Jen, do you have a inkling of what the implications are of going to the cap or above it?
Going up, when you say the cap.
The 225 for the QI, that's the top of our.
Right, I mean, I think that's our current V farm level. I'm not sure if there's anything else magic about that. There is just that, as Diva testified last week, there's a limit on how much we can go up in QI based on how much we go up in Quimby.
Right.
They're linked,
So
so, right, so I don't think that there's a problem. I mean, if we went beyond 225, we'd have to go up in Quimby. And I mean, the 225 number is just where V farm is, so it kind of makes sense, we would be equal to what our current level is. And potentially simplify things, because we'd be getting rid of 2 programs, V farm and Slimby. So maybe it would be easier for people to understand what their options are too, if there are fewer.
if we have money, if we. Let me know.
Talk amongst yourself.
We can talk amongst ourselves. So what strategically, what's the, I mean, we could send them the alt figures and say, you guys figure it out. Or if you take a more cautious approach and.
Yeah.
No, I don't know what strategically is the best thing to do.
I don't think that we should be negotiating with ourselves. I think we should be sending the
Letting them
option,
figure it out.
putting the option on the table that we think makes the most sense. And is the alternative proposal is lower than what the House did. And I think part of the House's proposal, they didn't have full information. I think there's some data that's come in since the House did theirs. So that's why they have Slimby as part of theirs. Isn't necessary. So if we put the alternative on the table, it makes the most sense because it matches the V farm level. It allows us to eliminate 2 programs, draws down a ton of federal money, and covers the most people.
It also requires, just so we know, it will require some administrative changes for V farm.
Well, I think all of them will, all of them
That
will require
yeah.
administrative changes, so this would get sort of biggest bang for the buck on those administrative changes.
I hear what you're saying, and I'm also very concerned about the level of funding that we might be able to access this year. So, and we do have technical analysis, and we could add language to the technical analysis. It'll take us forward. I am very concerned about suggesting a $10.1 million. It's higher than any of the options that were brought to us by DEVA, which they have felt is doable. So that's a concern. And I understand that healthcare advocate's role is to support Vermonters as much as they can, and I agree with that. There's no question about it. The public option that we prepared and looked at during our working group a few years ago was very clear about building a public option as complete as possible, and that's what we've seen from the House. And now we're seeing an alternative that still is very aggressive and all-encompassing. But it doesn't match where we are right now as a state in our revenue and access to funds. And it's perhaps thinking about putting all eggs in one place, I'd like to think about how we can take another step forward that helps Vermonters and isn't gonna dry up the revenue that we have. I know there's a big match here, but this is ongoing base funding over forever and continuing. My suggestion is to think, with all due respect to the healthcare advocate, I do think we should be considering, one of the options that were brought to us the other day by Diva. So Senator Gulick.
Good question. Chair, you're always great about thinking about health outcomes as a cost savings down the road. Is there any way, I know joint fiscal doesn't like to do this, but is there any way that we can, I don't know, think about what the cost savings in health outcomes will be in the alt versus the B?
Well, that would be a good technical question for technical analysis. I mean, surely, anytime you improve access, you're improving health outcomes overall.
Which is, but cost savings.
Who can answer that question?
No, but it's something that we often talk about. So.
Yeah, no, I totally agree.
I don't think, I mean, just remember the Diva testimony wasn't them making recommendations.
No.
They were really clear that they're just, this is their analysis, but they're not
Right.
making a recommendation, and the A, B, and C actually are the same, and they have the alternative option on their list as well, so they are just
Offering options.
offering options, not making they weren't putting forth what they think we should do. They
No.
were
Not at all.
doing the analysis.
I'm trying to focus on the fiscal reality of the state of Vermont right now a little bit. Okay, so there they are. So what we'll do is let's take a walk through Dr. Dinosaur and pregnancy and look at those pieces. Jen, if we could do that, and then we'll come back to this. We'll maybe have to do a little straw polling at some point. Does anybody else have trouble with their iPad waking up and recognizing the State House and sending messages?
Not today.
I did have to turn it off every day.
I'm waking up, yes.
Yeah, what's that?
Not with the iPad.
We are looking
iPad.
We are looking at section 3. Talking about the expanded coverage under Dr. Dinosaur. Section 3, it directs the Secretary of Human Services to make coverage available under Dr. Dinosaur to the following individuals whose modified adjusted gross income is at or below 112% of the federal poverty level for the applicable family size. Make it available to all Vermont residents up to 21 years of age, currently up to 19 years of age, and pregnant individuals of any age who are currently eligible but at a lower income threshold, up to 208%.
Okay, so what we heard on, again, we heard of numbers of population information from Diva. Find it. Oh, it's at the end. The question about where folks are and how they're covered. Oh, I couldn't do this. Not good at having on the door. This.
The pregnant individuals are up at 208% federal poverty.
Currently, yes.
Current.
And this would go to 312.
And the recommendation in the bill is. What page is that on, Jeff?
The section 3. Is on page 6.
I got it. Page 6. 312. for Dr. D and pregnant individuals. So information about, this, beginning with the residents up to 21, the information was that we were going to see a number of folks available for coverage. Was that 1,400 total? Or 900 total, and then 2 years, and then subtracting those who are on the exchange, which was 400, so it makes 1,400 people who would be eligible for Dr. Dinosaur, but then there were questions about what other coverage they might be eligible for. Would they be in an ERISA plan? Would they be on the exchange? So determining actual numbers was difficult. Whether that good thing or bad thing. And then there was information that about pregnancy based on historical data. So the other thing that we haven't talked about is about if we were to expand Dr. Dinosaur access up to 21, or in fact, if we were to expand it the way it is in the technical analysis, we could, I think there used to be a premium, correct me if I'm wrong, there used to be a premium on Dr. Dinosaur, I think it's $10.
I mean, there is,
Is there a premium?
there is in theory right now, there's been a premium invoicing suspension since the pandemic. I mean, during and
So the premium suspension is currently in place.
it's my understanding.
And though, so one of the questions I would have is if you expand it and you add a low premium, it was $10. Then how does that offset?
Right, that's part of the technical
It's
analysis.
in there.
It's
I
got,
couldn't find it when I
just
just
looking at
read
sliding
through.
scale cost sharing. Is,
Yes, Nolan.
yes,
For the record, it's Noel Manuel, the fiscal office.
It
It's not a lot of money.
is.
So in the governor's budget, they've assumed and proposed the continuation of that. And it's about $360,000.
Okay.
Just for what the current program is being deferred. So a small premium isn't gonna be a lot of money.
Okay.
so on page 8 of the bill, as part of the technical analysis, it has, looking at, proposed schedule of sliding scale cost sharing requirements for beneficiaries of all of the expanded programs. So looking at expanding eligibility, expanding the income level and age for Dr. Dinosaur, specifically, and then what it would look like to have sliding scale cost sharing for beneficiaries.
And that technical analysis includes expansion above 21.
Yes, it
Yeah, so it
includes,
doesn't include the below, doesn't include what we're looking at right now.
well, it talks about expanding eligibility to all Vermont residents up to 26 years of age, so.
In the technical analysis.
Yes, and then also talks about a proposed schedule of cost sharing for all of the expanded programs. So presumably the
Okay. So it
19 and 20-year-olds would come in without a change, would come in under the existing premium schedule.
And does it specifically say premiums
In what, in statute?
in the statute?
Yes.
Yes or no?
Yes.
Okay, because I.
Yep, it says, Secretary may charge a monthly premium in amounts set by the General Assembly. And I don't know offhand what has been set, but per family for pregnant individuals, children, and we're adding young adults. So I believe, and for whose family income exceeds 195% of the federal poverty level. So it's for certain, I believe it's certain beneficiaries who are allowed under federal law to be charged a premium, and it's for those with income over 195% of the federal poverty level.
About $48,000 for a family of 3. Maybe a little higher, 50,000. All right, so the questions that we have before us are to expand to all 19 and 20-year-olds. recommend that and the costs associated with it. And that would be an expansion of general funds in 26, 25 of, there you go, 300,000, and then the next year, 3.5. The next year is 6.0. The technical analysis is one time, 250,000. And we don't have the pregnancy, the pregnancy is included within the Dr. Guys dollars. So the question is to do both, the 19 and 20-year-olds, when we know that there might be some who are going to move on to other insurance coverages, but at these income levels would be helpful to have. One question kind of have to ask that about covering those 1,400 lives, unless they're on ERISA or an exchange or private insurance. And then the other question is about pregnancy. So for my part, I see pregnancy as taking my first choice. And then if we could, I mean, what we might want to do is to make some recommendations to the appropriations committees about priorities within this grouping, so that we, because I think we all, well, I think the public option expansion is important. The question is, will it also be important down the hall when we see base funding increasing over the next couple of years in Dublin?
Can I ask you, what do you mean by what are you calling the public option? Because
Right, there is not a public option.
It's not really, I know it's not a public.
There is, that is because of the technical analysis.
Exactly.
I know, to look at the public.
Okay,
I know, let's look at the public.
that's in the analysis.
I know.
So,
I know, but for me, it's the beginning of that.
that, with what is, that, the whole
Medicaid
thing.
expansion.
Yes, okay, I mean, obviously, I think we should do it all. This is the bill.
You better say
yeah.
that, Senator.
This is the bill I worked really hard on, and I think the House did a great job with it. And I would love to be able to support it all, and I think the Senate should consider revenue options to be able to do it. Because I think it's worth it, and it will help us draw down a lot of federal.
So what you're, go ahead.
And-
No, go ahead. No, I like what you're saying, and this is what I say, we could make some recommendations. Go.
Yeah, okay, well,
Yeah.
that would be good. I mean, I do think it's worth considering the revenue options to be able to do the whole package and to do the alternative for the MSP program that the healthcare advocate has recommended. Because even that is not as generous as we could go, so that's already coming down a little bit. I agree with you on pregnant individuals. Yes, these pregnant people are moms are having babies, and then their babies qualify for Dr. Dinosaur, but they don't.
Right.
And so it doesn't make sense. We should have pregnant people at the same level as children so that they can get the prenatal care and the postpartum care and
And that
pediatric
comes in
care.
with what Joseph Barnard was sharing with us earlier.
Yes, and part of the technical analysis includes the rate increases. So all of this takes a little bit of time to implement. So the technical, I don't think we need to do the rate increase immediately. That's part of the technical analysis that could be in place by the time the expanded Medicaid coverage goes into place. So I think I would like to do the alternative option and the pregnant moms and the technical analysis. And of course, I would like to do the 19 to 20-year-olds. I hear you that some of them are covered elsewhere, but there are a lot of people in that age range that have a hard time getting affordable health insurance coverage. Or they're in this sort of weird netherworld of their life where they're not sure, they're moving jobs around, they're in school part-time, they're working, they have a hard time getting good coverage. But I would probably put that at them at the lower part and wait for the technical analysis, I would be willing to do that. That's the thing I would be willing to do. In terms of my
Okay, this is
priority.
good. Let's listen to other folks. So does anyone else want to weigh in on everything that we're talking about?
I'll just make an observation, which is that it's so frustrating doing this work in buckets, in silos and in a vacuum, because we do have bills up on the wall that will ultimately potentially save us money, like S98. So what, it would be so nice to see a long-term, savings payments, revenue generators, I know I live in a fancy world, but that would be helpful.
Modeling would be great.
Because we do have some potential to be, recouping some money over time. I've been clear that I don't think a for-profit medical structure is a good one, so I think we can aim high and send what we think is best and then let them figure it out.
But they would like to have us make a recommendation that doesn't leave them holding a bag, to be quite honest with you, and that, it's fair. I know we're in budgetary constraints, so we are, we're looking at increases that are significant. We could make a recommendation that says, if we would like to see revenue raised to accommodate the alternative option, and we could say that. If that's not possible, we might consider option whatever it is there. I think we need to be considerate of the processes going on, both in appropriations and in finance. So think of that. And then I do agree about having the pregnant people go first. And maybe the technical analysis will help us understand the 19 and 20-year-olds a little bit better. If we could do the 19 and 20-year-olds, yes, please do it. And I think we can leave we can have it be our list again, as we have on other things, some prioritization.
Well, yeah, now if we can do that, then we can offer.
There's no reason why we
Yeah, we
can't
can
do that.
offer the alt program first, and a B as a second
Yeah.
tier.
Yeah.
Well, if we're gonna,
So I haven't heard from Senator Williams and Senator Weeks, and I'm interested in your thoughts.
I would put pregnancy above 19 and 20-year-olds, but overall,
So you wouldn't want to do any increases for
I don't want to,
Medicare savings?
don't want to increase revenue via taxes or fees.
Okay. If one of the options were within the budget capacity, would you support that?
Yeah, I don't have the bigger picture. Of
Yeah, that's the thing.
capacity, So I can't say that this is more important than the hundreds of other options that are being considered by the appropriations committee. I really don't have that insight.
Well, let's put it this way. Right now, there are people who are on Medicare who are not affording heat, food, and other daily needs because the cost of Medicare is not covering their health care. So that for me is a very compelling reason to move forward on the Medicare savings program. And it's been that way now for several years. Fortunately, federal dollars during the pandemic did help a little bit. But now we're seeing the inflationary pressures that are really pushing on people on fixed incomes. The Medicare program isn't the be all end all that people think it is, because there is the monthly premium, and that monthly premium competes with paying your taxes, paying your food bill, paying your other bill, whatever it happens to be. That's what's really pushing that decision making, at least for me.
Yeah, I get that, and I sympathize with that. But I feel that we're treating a symptom and not a cause. And I believe the cause is economic, And I'm not sure of what the other options that appropriations is considering are addressing the economic conditions.
I don't-
That's my.
I
that's
mean,
my-
that, pushing the economic issue is something that is not in this committee. We do have the responsibility for looking at the economic benefit and welfare of citizens, and that the Medicare Savings Program and the expansion of Medicaid does fall into that, does help you. So that's all I can say to that. We are not the Economic Development Committee. We're not the Finance Committee where we put money into veggie, and we're putting a huge amount of dollars into supporting businesses. So I see this as a real investment in our economic base. If we can't help our folks, our senior citizens who have worked for years and years and years, I don't know what we can do. And if you wanna, I mean, if you support pregnant people, you're actually supporting an increase in population in the workforce. Who said that? Cradle for fear. So Senator Williams, I know you're over here pondering.
I will support the bill, first of all. And, you know, when you talk about, you know, getting more federal funding, it's still our tax dollars. So there are more components of the bill that we haven't even talked about that we're going to support. So
Okay. So you don't have any, neither one of you has a recommendation for improvement to the bill at this point, except your whole pregnancy about,
that's it.
okay,
It's about the-
all right. So, so committee, we've got a few minutes here. Can we do this? Do at least the three people who agree to the bill, on second the bill, agree that we'll try to present, sort of a tiered option from the committee for, we'd like to cover the alternative and that if additional funding is needed, that we would do that. And that we would support, I wouldn't support option C. But I might support option B. We would support the Medicaid DIVA option presented as option.
What about option A as the second?
I just said I wouldn't support option C.
Okay, well, cause we're talking about B, and it seems like.
I want
Go
B
from
the
the
best.
alternative to A.
B is where I landed, so, and I'm supporting that, but if you think that we should be listing the options presented by DIVA.
Well, I'm just curious about the process here, because
Well,
are we,
We're gonna offer our recommendations and then it's gonna go where the money is.
well, are we passing the bill out or with our recommendations, or are we just writing a letter to them? Is the language gonna go in the budget? How's that working?
We can pass recommendations out today and then we're gonna pass the whole bill out. Because there's other language in the bill that's important to us, including the technical analysis. So if we could go through that a little bit today, as well as our options, we'll do that. If we can do it all
Okay.
together, that'd be great.
Cause the technical analysis also costs some money.
Yes, it costs $250 or something.
$250. It's a little more than that.
30 that.
You know, A is between alt and B.
Yeah, that's what I mean.
That could be a happy medium.
That's what I'm thinking. That's why I didn't leave it out. I mean, we could recommend alternative A, option A, which is between those two, and it would help significantly in decision making.
I mean, if we're gonna just write to the appropriations
pass
and
the bill out.
finance, oh, you want, okay. And are we assuming that in the passage of the bill, we are not passing the revenue part of the bill? Cause there's revenue actually in the bill.
We're gonna leave it in there. That will go to finance.
Okay,
If you wanna take it out, we can take it out.
I don't wanna take it out. I mean, I think we should be considering revenue options. but, I'm just a little confused about the process and where.
Process is we're gonna choose our options, make our decisions. We can ask Jen to put them into the bill. And we can pass the bill out with those in it. And if the bill can get out today or tomorrow, I can bring our recommendations to the appropriations committee, or they'll see it when it pops up for notice. That's it. So the suggestion has been made by Senator Gulick to support option A. And Diva, and use those numbers. I go along with that. And then and then leave the pregnancy piece in. And add the full analysis of Dr. Dinosaur in the technical analysis.
Um,
And then the other question is on the recommendation from Vermont Medical Society to include obstetrics and gynecology as for primary care. I don't know how we put codes into a bill. That's like a question for Legend Council.
I don't know how we, I mean,
I don't know.
if we want to put codes into.
Like, can I ask a question?
Sure.
So I'm thinking about the fiscal,
Yes, yeah, good.
this is new, what is that proposal and does it cost money?
Option A,
No, you're saying about
which?
the primary care.
the pregnancy codes, I
Oh,
actually,
okay.
that's the thing that Jessica just suggested.
Oh, I understand.
I mean. Jen, correct me if I'm wrong, but the bill, and this gets to what you're talking about, Nolan. The bill does not, the increase in the pregnancy doesn't happen immediately.
Right,
It happens starting in, I think, January 1st, 2026.
right.
So. The codes, as long as they're in effect January 1st, 2026, that would be okay. So as long as we're clear in the technical analysis that they should
Implement.
examine the, those
Right.
codes as part of their analysis of the expansion, that would work. Then we don't have to put it in the bill right now. It's just part of the analysis that they look at. So that, yeah.
To ensure reimbursement equity.
I don't love option A as much as I love the alternative that our healthcare advocate proposed, but if you two are comfortable with option A, I can live with that. And pregnant women.
Let's try that. There's no promises down the hall on this. They may require additional funding, but that's what we'll go with.
And to make sure that in the technical analysis, it's clear that both the codes part of it and also the examination of adding 19 and 20-year-olds, or does it already say to go up to
Doesn't have.
It just says, it just says go up to
26?
up to page 26.
So that's,
Yeah, so good it was.
So you'd be taking 19 and 20 out of the do it and having it sort
in
of
the analysis.
presumed in the analysis
Okay.
because it's up to age 26.
Okay,
Is that what I'm understanding?
yeah, I can live with that.
That's all that good. I'm living with it too.
Yeah.
In different directions. So, but this is good. I think this is a good place to. Thank you, and thank you, Senator Gould, for your suggestions.
Right there on paper. Good one.
Okay, so Jen, what else is there that we need to look at? And,
Well, I think, so we're making a change in section 3. We are making a couple changes from the technical analysis to, well, one visible, one not visible. The not visible one is that we're taking the 19 and 20 out of the of section 3 and having them swept into section 4 in the analysis of expanding Dr. Dinosaur to age 26 and including something in the provider reimbursement rate area about looking at the OBGYN, the two different, both the codes and considering as primary care providers, or did you want to say something more?
Primary,
Affirmative.
OBGYN primary care.
Right, but I think, not to put words in Jess's mouth, I think they, BMS had wanted clarification that OBGYNs can attest to being primary care providers. Was that specifically in the context of this or generally?
Jessa Barnard, Vermont Medical Society, we would prefer generally, because we think it's a problem even with the existing primary care attestation program, but certainly, I mean, certainly connected to
Otherwise,
the
you get
expansion.
into this.
Yeah.
Decision making about where it is and where it isn't,
All right,
so.
so we'll add the coding issue into the technical analysis and specify just generally that OBGYNs can attest.
So I could be
These. If you're going with option A, so if you're going with option A, then you're expanding QI up to 200%, which means you don't want to, I assume you don't want to get rid of V farm. So we'll want to take out the V farm repeal and maybe just direct Diva to maybe add to the technical analysis what V farm should
Affect
look like.
Yeah.
Any proposed changes to V farm as a result of the expansion?
Yeah. The heavy lift is gonna be getting it to option A. I'm very weak right now, but I'm gonna.
Okay, you okay?
I was metaphor.
Oh.
Don't I hear?
I'm
Sorry for that, yeah, that's my husband's car yesterday, it's all they have, I am really weak. He had to do it.
All right, so there's that piece. There,
I think the appropriation is right.
right, so let's see, yes, so we're gonna, thank you. So we're gonna need to change some of the method of appropriations because the Dr. Dinosaur eligibility expansion will be smaller.
Smaller.
I need to know what the numbers are there. I think the technical analysis hopefully stays the same, even though you're adding a couple of things to it. And I don't know, the 200,000 may still be okay for implementing the MSP expansion because I think it had to do more with the programming.
She said, I think that Stephanie said that.
Yeah, the
Because it
costs,
wouldn't matter which you
the
pick, we
costs
still
are to
have to
change
do
the
X, Y, and
parameters
Z.
of the access system.
Yeah.
So.
Yeah.
So that one can stay. But
Well, where is the Dr. Dinosaur appropriation?
it is,
800. Oh,
it
so
is
you're-
1.2 in global commitment fund, 1.2 million in global commitment funds.
So that should come down.
So that would come down and then the amounts for the general fund and federal funds for that.
Why would it happen in fiscal 25? Because
That's when they're doing the work.
this is just for the changing the implementation.
Yeah.
This,
they have
the
like
analysis, what they have to do to switch things over.
Yeah, IT work, contract work.
Right, if they're only making changes to income eligibility for pregnant individuals. Seems likely that would have less of a cost of a programming.
Does, they had administrative costs specific for each.
For each.
So if you're taking out the young adults, you can reduce the implementation costs as well.
Do you have them?
Yeah,
Yeah.
it would be one AGF,
One,
$108,000 in general fund, 600,000 in growth, so it's basically half.
By doing that, we can certainly argue
Amendment.
strenuously for federal A.
There's mixed. It's,
but everything is cut, if everything is cut in half, I can just cut all of them in half.
for the implementation costs, just cut the implementation cost, not the other stuff. We're just talking,
So do you want I have an idea. Let's take a quick break. And let's allow for Jen and Nolan to confab and we can come back and we'll move on to 233. Because we do want to get some testimony from, or we can continue and get testimony, Jen. While, we won't go off live, Senator Good, but we will, because we can go ahead. But we'll stick with, and we'll hear testimony with Charles Becker and, Sam Hollmeyer. It's the only time I get them. So let's do that, and you know, can sort out what might be needed. Just heading off. Are both of them on?
It's 11:15 right now.
What are we hearing? Testimony on 233. We're trying to, we've had people who made a request, so. Accommodate
33.
and it will be a long.
so the budget.
Oh.
180,
Oh, yeah, I thought you said.
and it would be 600.
Oh, you said?
And then difference.
No, I
whatever.
No,
For kids.
Charles, my brain heard James Pepper.
I know.
And I was like, wait, are
And then you
you,
have-
what was that?
Good morning.
Sandra, how are you?
So we're ready to hear from Sam Hollmeyer. Thank you.
I mean,
And then we'll hear from Charles Becker on 233. Why don't we give the room a minute? Clear.
Madam Chair, would you like me to sit
And then-
right here?
Let's see.
Sure.
All right, good.
You ready?
And then I need. Yes. So.
Right, yeah. Like.
Yeah. Thanks a lot.
We need to decide that.
Right, you guys all have time.
When you want to talk,
Wanna-
talk now.
That's.
Can I go talk to him? Outside.
Huh?
I gotta go talk to Nolan. So I.
Don't talk that.
All right.
Because I want you back.
I'll be back to vote for sure. I won't go far.
I want you back. Okay, let's
It's nice to
go.
be wanted by you, Jenny.
What?
We all want you back.
We're gonna vote without you.
Don't go without me.
We're gonna vote.
You won't.
Okay, so, thank you for being here, and just so you know, our time is extremely tight, and we do have your testimony.
Great.
And so why don't you give us, your testimony?
Absolutely.
Thank you.
Thank you so much, Madam
And
Chair.
so before you start, I'm gonna introduce ourselves.
sure.
Senator Jenny Lyons, Chittenden Southeast.
Dave Weeks, representing Wilton County.
Martine Laura, representing Chittenden Central, which means nothing to most people. Burlington, Winooski, Essex.
Awesome.
Yeah, nice to meet you.
Nice to meet you as well. Thank you so much for having me today.
Senator Hardy is from Addison County, and Senator Williams is from Rutland County.
Great.
Okay.
Well, thank you, Madam Chair. I really appreciate, and members of the committee, I really appreciate you allowing me to testify today. My name is Sam Hollmeyer with PCMA, which is the National Trade Association for America's Pharmacy Benefit Managers. And PCMA and its members serve over 275 million Americans with prescription drug insurance. Like the Madam Chair did mention, I did submit written testimony, so we'll keep my comments brief to House Bill H233, to which PCMA is opposed. Before I dive into the specifics of my testimony, I do want to start with the onset that no one is required to use a PBM. Plans and payers choose to use a PBM because they save on prescription drug costs. So the plan offers benefits to their employees. Nowhere does it say that they have to use a PBM, but because of the negotiating power that PBMs have with pharmacies and drug manufacturers, plans use them again because it saves on costs. So now we get to the specifics of the bill that we have with House Bill 233. The first is with an ERISA preemption issue. So the definition of health insured, we are concerned it does appear to apply to ERISA plans. States that attempt to govern plan of administration of ERISA plans are preempted by federal law. And we request that health insurer be struck from the bill in H233, as it's already found in Vermont statute section 9402. So health insurer is already defined in statute. And we're concerned that this expansion of the definition would bleed over into ERISA preemption. Next is a ban on spread pricing. We're concerned that this will remove the ability for plans to pay for drugs based on what is best for their plan and patients. Spread contracts offer more predictability for plans when paying for drugs. And again, we think that this should be a plan choice and not be taken away from plans to choose from. So again, PCMA requests that you strike section 3612 sub F, which deals with spread pricing. Next in the bill is copay coupons being applied to a patient's deductible. This is a marketing tool used by drug manufacturers to steer patients towards more expensive brand name drugs when they are typically cheaper generics available. In other words, this is a free or reduced copay for a patient, which does sound great for the patients, but it does add to overall healthcare costs because the plan does have to pay for it, where the patient wouldn't have to when it comes to the copays. These copay coupons are banned in Medicare and Medicaid because it adds to the overall healthcare costs. Therefore, we request you strike section 3612 sub capital F sub lowercase I, which deals with copay coupons. Finally, we're concerned that this bill will create a private right of action, and we're concerned that this will allow pharmacies who are direct competitors with PBMs to file frivolous lawsuits aimed at PBMs disrupting the contractual relationships. We feel that pharmacies already have the ability to do this through DFR, as well as through the contractual arrangements that they have with PBMs. So we request that you strike section 3613 from the bill. Thank you so much for letting me testify today. I did try to keep it brief. All these comments that I just made are in my written testimony that have been posted online, and we are in opposition to H233, and I'm happy to answer any questions from the committee.
So I'm looking at the ERISA piece that you have there, and ERISA precludes us from regulating ERISA plans. But if a ERISA plan doesn't include a PBM, PBMs are outside of that. And I'm not sure how everything within a relationship between an insurance company and an employer, or an employer and healthcare, all entities and organizations are not covered by ERISA. ERISA was passed way before, I think, PBMs started. So I'm trying to understand the logic with that connection that you're making.
Sure. So our ERISA argument is that when states try to enact legislation such as this to impact plans that go beyond Vermont state lines, they're self-insured plans.
Doesn't affect the plan, it affects the PBM and offers transparency for how PBMs operate.
Thanks for the question.
Yeah.
So let's use spread pricing as an example. That's a plan choice. PBMs aren't forcing a plan to do pass-through versus spread pricing. This bill would propose a ban on spread pricing, which we feel would interfere with a plan being able to design their own benefit, which is where we believe would rub up against ERISA preemption.
I can understand. All right, thank you. Questions, Eddie?
No, very clear.
Okay, very clear. Thank you.
Thank you so much.
And thank you for being here.
Absolutely.
It's very helpful, and thank you for your complete written testimony. I did read it, and I will read it again. Well, that's all.
Thank you.
And we also have Charles Becker. Thank you for being here.
Hello, thank you for inviting me.
I think you also have written testimony for us.
Yes, I did also submit my written testimony. So I believe I think I've seen it on the website already. It's up there.
Yep.
Okay. So, yes, I'll also try to be brief. Thank you very much for having me. For the record, my name is Charles Becker. I'm a staff attorney with the Office of the Healthcare Advocate. I just want to start off by briefly addressing the health insurer definition issue. If Jennifer Carby were here, she'd be the better person to answer this, but I'm 99% sure we did not tinker with the definition of health insurer. We're moving that definition for 9402 into this new section. We're consolidating all of the PBM related statutes into this new section. And I'm pretty sure we didn't tinker with that definition. So although I agree that the definition does sort of suggest that it might include ERISA plans, there is a DFR regulation longstanding since at least 2005 that says that they interpret that definition of health insurer to not include ERISA plans. And that is a bulletin I could provide to you if you wanted to reference that.
That would be helpful.
Okay.
Thank you. But we don't want confusion in particular with, the pharmaceutical organizations at,
No, of course.
PBMs, yeah.
Yeah, of course not, no. So to get to my main testimony here, and just thank you, Chairwoman Lyons and members of the committee for inviting me here to testify today. On behalf of the Healthcare Advocates Office, I want to express our support for H 233. H 233 will strengthen Vermont's oversights of PBMs, shrink the proverbial black box, and help Vermonters struggling with high drug prices. I want to let you guys know that I've been listening to your testimony throughout this legislative session, and I've heard two things, at least more than two things, but at least two things have come through to me that I understand that you guys is important to you. And one is that you want to do something to address high drug prices now. And another thing is that you want to make sure that you're using state resources carefully. And I believe H 233 addresses both of those aspects. First, to how H 233 addresses high drug prices. It does so by banning copay accumulator adjustment programs. I spoke to you back in February about these programs. This is the practice of not counting manufacturer coupons towards deductibles and out-of-pocket maximums. This bill would ban that practice. I can see that banning copay accumulator adjustment programs does not solve the problem of high drug prices. But I don't think it makes the problem worse. And I can point you to a study I did so in my written testimony from the AIDS Institute, in which they did a comparison for benchmark plan premiums in states that passed copay accumulator adjustment bans in the year before and the year after, and they noted no significant change, no noticeable change in premiums as a result of copay accumulator bans. Copay assistance, however, does help patients. It helps patients in the moment. When they're at the pharmacy counter and they use that coupon card, they leave that pharmacy with more money in their pocket. And that is money they can use to buy food or pay their rent or put in savings. It is money that the patient gets to keep that does not go into the pharmaceutical system. Some people describe copay assistance as a bandage on a bleeding wound, and I think that's a fair comparison. When you're bleeding, though, in this case from high drug costs, and there's a bandage available, you're going to put that bandage on and you're going to want it to stick. You're going to want it to count. Stopping the bleeding of high drug costs, that is a systemic issue that individual patients are not able to solve on their own. And a part of what that systemic problem is that we have a system where everyone is clamoring for a rebate. Everyone wants a rebate, right? And rebates have the effect of raising drug prices. There's another study I linked to in my written testimony from the University of Southern California Schaefer Center, where they find that for every $1 of drug rebate, drug prices go up by $1.17. So the practice of demanding rebates, which is something that PBMs are doing on behalf of their clients very aggressively, has the impact of driving up drug costs.
And somebody gets that extra dollar somewhere.
Someone gets that, and someone has to pay for it too, right? Right. So in its current form, H 233 does not address the rebate issue. That means in the foreseeable future, drug rebates will continue to exist and drug prices will continue to be high. And in that kind of a system, patients need copay assistance, and they need that copay assistance to count. And I just want to draw your attention to a letter that's been posted on your committee website. This is from nearly 20 patient advocacy organizations for patients with chronic and rare diseases who have written to you to say, we need this copay assistance to be able to afford our medications, and we need that copay assistance to count. H 233 secures this lifeline for patients by requiring PBMs to count all payments made by or on behalf of a covered person. And it also includes important compromise language that if there's a generic equivalent available, then copay assistance does not have to count. So this addresses this controversy that potentially drug manufacturers are using copay assistance to lure patients to more expensive brand name medications. We address that by including this language. The spread pricing issue, I would just say that from my perspective, this is a tool in the PBM's black box, right? This is a way H 233 would ban the practice of PBMs charging their health insurer clients more than they reimburse pharmacies for drugs. That's what spread pricing is. It is the opposite of transparent, right? And if we want a drug pricing system, a drug distribution system that is more transparent, so we can see where the costs and where the money is going, banning spread pricing would be one way to one modest step to go about that, to making the system more transparent. So for that reason, the HCA supports the ban on spread pricing, as 12 other states have already done. So we would not be the first state to do this. I want to address briefly how H233 makes careful use of limited state resources. The major innovation in H233 is it takes Vermont from being a state where PBMs need to register to being a state where they need to be licensed. It includes express provisions for DFR enforcement of our laws and creates 3 new positions at DFR. Full-time staffers who will be responsible for ensuring that PBMs comply with our laws. And so how is this fiscally responsible, adding 3 new positions? Well, the bill is designed to raise the revenue to pay for itself, right? The fees that the fiscal office and others have developed were designed to raise the revenue to pay for these positions. And in the ramp-up period, those positions would be paid for with money that DFR already generates, doing the work that they do. And then, as you heard from DFR, this licensure, having the authority to revoke a PBM's license, gives their enforcement authority teeth, right? So I believe that was the exact phrase that they used. And it specifically gives the commissioner of DFR authority to investigate and audit pharmacy benefit managers. And I think what they're going to find when they do conduct some investigations is that PBMs are not faithfully adhering to our state laws, and there will be opportunities for fines to be levied. And I did some research into the state of West Virginia because they have some similar laws as we were working on H233. And what I found in one state, West Virginia, a small rural state like Vermont, right, that in 2022, they levied fines of $270,000 against pharmacy benefit managers, and in 2023, $74,000. So there will be opportunity for fines to be generated as a result of this law. And eventually, fines will lead to compliance. Compliance with our laws that you all passed to make drugs more affordable for Vermonters. So I think that would be a good return on investment for passing this bill. Very quickly, I know you all are very short on time. I just want to mention, I think I said at the beginning, I'm not sure that I did, that we will be proposing one amendment to this bill. You heard DFR say the other day that they oppose the provision in section 3613B3 of the bill that would give the Healthcare Advocates Office, my office, the right to review all materials that a PBM provides to DFR in the course of an audit or investigation. Although we disagree, that granting my office access to this information would, as DFR testified, impair their ability to do investigations. We disagree with that. We have concluded that giving us access to all materials is too broad, that's too much, and it has too many unknown, potentially legally fraught implications. So we propose significantly narrowing the scope of our access to just those materials that are generated at the conclusion of an investigation. Specifically, DFR's initial examination report, any PBM response or rebuttal to that report, the final adopted report, and the commissioner's order adopting that report. Although these materials might already even be public records that we could access through the Public Records Act, we think including us in this piece of legislation signals that the legislature, as you've done so many times in the past, that there's value to having the public advocate have a role in healthcare oversight in this state. And it furthermore would assist us in our statutory obligation to identify problems and recommend solutions.
Thank you for that. We don't have that. I know you did send me the email with that recommendation. And if you could send it so we can put it on our webpage.
Sure.
And I should have copied Jen for that.
I did not, no.
So can you?
I didn't want to get too far ahead of things.
No. Please send it to Jen and to Kiki, because I think it does resolve the issue
Okay.
of BFR, and that's
Great.
important.
I will do that.
Yep. Okay.
So that is all I had, unless you had any questions, and I thank you for the opportunity to testify.
Thank you very much. Helps. Okay. So Jen.
Yes.
Yeah. We've got about 25 minutes to look at two bills. And let's see where we are here. I think we're. Yeah. We also, we'll be looking at 233 on Thursday as we move forward. And we can also look at language in 721 again on Thursday, but if we have something on 721 today, that would be amazing. For tomorrow, we can finalize a vote on that. We may be able to finalize a vote on 233 tomorrow. And make them to that. So you've heard the testimony, did you hear the testimony from the, PCMA, Pharmacy Benefit Organization indicating that, by passing this bill, that we would be violating ERISA? And the example was given that spread pricing is currently a part of a contract between PBMs and ERISA plans, that if we pass this bill, we would be reaching into insurance companies. I'm not sure.
Jennifer Carnby, Legislative Counsel. I'm not aware of any potential ERISA violations. We're not impairing any existing contracts, supplies, but new contracts that are issued. There's actually a sort of a transition period for contracts that are currently in place and will be in place through 2029 or the middle of 2029, which was done specifically to avoid affecting existing contracts.
And we're not redefining insurance companies. In the bill.
Insurance companies, and the Supreme Court has weighed in on PBM role in ERISA plans and the extent to which states can regulate. So, okay. So we'll certainly see going forward. I'm happy to look at any specific concerns that you may have. I apologize, I have to meet another member.
Committees, my question for us is, why don't we ask Jen to incorporate the language that the healthcare advocate, Charles Becker, has suggested, and then look at the bill and make a decision on the bill and go forward with a vote. We can do that, probably do that tomorrow morning.
I'm sorry, because I was in and out. Can you just give me like a 10-cent version of what was suggested?
Oh, suggestion was that the initial, remember we heard from DFR and the healthcare advocate had asked to have all the documents that were filed by a PBM, an insurance company, related to PBMs, and the healthcare advocate really realized that their request was overly broad and have asked for some of the documents that are resolved after DFR goes through an evaluation. So that came from healthcare advocate, and it does resolve the concerns that we heard from DFR.
Got it.
So we can look at that within the bill.
Less paper.
Huh?
Less paper.
Yes, and less angst.
That's the 1 cent version. Sounds like a playground outside.
But now it's spring.
Kids outside playing. Nice. I like your plan. That sounds good.
Okay, so let's do that, and then we'll come back and we can look at the language, Jen, if you can get it to us, and then we'll come in and we're just gonna entertain a motion.
For this bill?
Yeah.
You're asking for language for tomorrow.
Yes. Yes,
So-
tomorrow,
721 or 2.
2:33.
Tomorrow we'll entertain one.
Yes,
Got it.
tomorrow morning. Yeah. I'll just, Kiki and I will sort out the implications for the agenda.
Yes.
Indeed.
Aren't you? Okay. Yes,
Mike Fisher, just a question, if you or the committee was interested in entertaining the language, the concept I suggested in the 7.1 analysis about future steps for MSP.
about future steps for,
MSP.
yeah, I mean, we're not quite there yet, but we can do that.
Yep.
We're good with that. We can do that.
Can you add that to the technical
Yeah,
analysis?
so,
Yeah.
um,
Let's do that right now. We're right at 7:20.
yes, I mean, I'm wondering if we wanna, yes, I'll look at how to do it. Maybe we will fold that into the V farm. What do we do about V farm and what might be possible for MSP expansion in the future?
Perfect.
Yes, these are just to recap again on what I have for 721. MSP, we're going with, option A as outlined in the GBA and health proposals. We're doing coverage for pregnant individuals up to 312% of federal poverty level only, taking out the 19 and 20-year-olds. We are adding the OBGYN coding issues to the technical analysis. We are specifying just in general Medicaid law that OBGYNs can attest to being PCPs, primary care providers. We're gonna take out the VFARM repeal, and that's the technical analysis to look at any appropriate changes to VFARM as a result of the expansion and what might be possible for expanding MSP further in the future. And then fixing the Dr. Dinosaur appropriation, the implementation appropriation, cutting that in half because they only have to do one piece of it.
Say that part of the last part again.
Just cutting the appropriation for the Dr. Dinosaur implementation in half because only the pregnant individuals.
Yeah.
All right,
But keeping the technical analysis operation as is, right?
Yeah.
Change.
Yeah.
yes, and do you want to see this as a strike also? It's going as a single package down
Do
the
it as
hall?
a strike off, makes it easier all the way around, and,
Okay.
I can convey where we are down the hall temporarily. The question I have for you is the timing, and you see it.
Well, yeah, I mean, I'm booked pretty solid until about 3 o'clock this afternoon, at which point I will approve the actually drafting, since it's actually drafting these things, so. Are you wanting to see it later today or tomorrow morning, or when do you want?
The sooner we get it, the better. That allow for us to look at it, review it, and then tomorrow morning we can entertain a vote.
Do you want to see it as markup with a clean version for tomorrow? Is that the best way to show you what has
Yes.
changed?
Yes. I know it's,
Okay,
we're pushing the envelope with the end of session.
yeah, and the changes you're making are not
No,
super extensive, so I don't feel
no,
overwhelmed by the drafting.
good. All right. So tomorrow morning committee, we'll have the drafts that Jen sends to us. We got Kiki will put them up on the webpage. We can come in and vote on those two. I think we'll be able to do it
Grab you for a second.
Sure.
right off the bat, and then we'll be talking about H72. That we have sufficient time tomorrow morning to do all three of those bills before we pick up the next big decision-making process. Okay. And I did send some comments on 879 over the weekend as well. Doesn't mean that they're in stone, but they are, I hope, helpful for you. Anything else? Yes, sir.
Just one question on, looks like we're picking back up H661, child abuse and life investigation. Friday. Just curious if, you may have answered this already, but, is it going to the judiciary at any point?
No.
No.
No, it's not. It's right here.
So they don't need to look at,
They might look at it while it's up on the calendar. They might go have a little look at it to make sure that it all conforms. It won't be sent to them. Okay. And FYI on 661, some really important bill. And I will dig out, I just haven't had time to go through and find the Parent Representation Center report. I have a hard copy. It's not something that goes up automatically on a web page because it comes from an outside organization, but let's see, maybe Keith can copy it for you. That probably the best thing, that rather than try and scan it and put it up on the web page, so I'll get copies of that for you.
I'm really glad we're digging into that bill, and I'm really thankful that, you know, Secretary Chris Winters took really
Chris Winter
highlighted it and brought it to the fore. I think that's huge.
Yeah, it is. It's really good. Okay, so we can call it a wrap today.